So I just wanted to briefly introduce you to some of the different physiotherapy techniques which are available for people that have secretion clearance difficulties. So I just wanted to make you aware, I guess, a very brief overview of some of the different adjuncts. At the end of the day, there's options out there and they require referral to physiotherapy for assessment and management of these different techniques. I don't know if anyone maybe saw the 6 o'clock news last night on Channel 1. They had a segment about a consultant from Starship talking about bronchiectasis in children, and they had a little kiddie using a PEP device, which I'll show you shortly. So there are a few different physiotherapy techniques which can help with secretion clearance. There is huffing. The concept behind huffing I'll explain briefly about huffing can help to bring secretions up to a place where you can get an effective cough to clear. There's the active cycle of breathing technique, which is probably one of the oldest respiratory physiotherapy techniques that we have, but still used widely, and it still works. And it's a series of breathing exercises which can just get airflow in behind those secretions and move them to a proximal position where you can actually cough and clear. So we use the active cycle of breathing with an education device, and by an education device I mean we often teach the active cycle of breathing with a incentive spirometer. Incentive spirometers have been used in surgical wards for a long time to try and get people to take bigger, deeper breaths post-surgery, but we have been using them with the active cycle of breathing just for patients to understand how to take that bigger breath and how to do it well. And then we sometimes add in postural drainage. There are some other slightly more complicated breathing exercises called autogenic drainage, not used so much in New Zealand. And then there are some adjuncts, and this is the acapella, the TheraPEP and the flutter, which I'll just very briefly touch on. But at the end of the day, my all-time favourite is aerobic exercise. So if any of you have had the flu recently and you've gone and done some exercise, you'll know that that brings the phlegm up. So there is nothing that works quite as effectively as doing some aerobic exercise to help shift that phlegm. So there is some evidence around to show that the active cycle of breathing technique is effective, and there's a recent systematic review done by Julia Bott, well it's not that recent actually, in 2009, that compares the different techniques. There has been shown to be improvements in lung function, in blood gases, in dyspnea and oxygen levels from the active cycle of breathing technique, but these benefits are obviously quite short term. So the rationale behind the active cycle of breathing technique is that in order to mobilise those secretions, you need airflow, and it works on the principles of increasing ventilation through those collateral ventilatory systems, the principle of interdependence, and also using that equal pressure point to expel the secretions. So going to the collateral ventilation, which is not used widely in tidal volume, but can be really effective through the active cycle of breathing when you're doing those large thoracic expansion exercises. Then you can help open up those interconnecting channels and therefore get airflow behind the secretions and mobilise them. And also the principle of interdependence. So that's by taking the larger volume breaths, that pooling effect between adjacent alveoli helps to open up the airways and again increase that airflow. So this is just touching on the equal pressure point, so that's that point in which we get narrowing of the airways. So the equal pressure point comes into effect when we're doing the huffing technique, and the huffing technique is about when you huff, and you do huffing from different lung volumes, you're getting that squeezing effect of helping to move the secretions from the distal airways up to the proximal airways where they can actually be coughed out. So this is just a very simple diagram of what the active cycle of breathing technique actually involves. So it's a cycle where people start with breathing control. Now breathing control is relaxed tidal volume breathing, then moves into deep breathing exercises which need to be taught well so that they're deep diaphragmatic breathing exercises and not just blowing up your chest, but we do a series of deep breathing exercises followed by more breathing control, and then it's the forced expiratory technique, which is a combination of the huff and breathing control, which will stimulate a cough if it's mobilised the secretions up to the upper airways. And that cycle goes around for as long as it's needed to until those secretions are cleared. So that active cycle of breathing technique can be done in postural drainage positions. Postural drainage is still used widely in children, particularly with CF. It's not used so much in adults anymore because it's not particularly well tolerated, particularly the head down positions. If you have gastroesophageal reflux, or it can cause desaturation, it can cause headaches, it can just actually not feel that comfortable. So not many patients liked it and stuck to it. The idea behind postural drainage is that you're using gravity to assist the drainage of secretion. So thinking about the anatomy of the bronchial tree, where the secretions are, and therefore positioning people to use gravity to drain up towards the large airways where those secretions can actually be coughed up. To do postural drainage, you really need to be in that gravity-assisted position for quite a period of time to allow gravity to have that effect. So you're talking a minimum of 15 minutes, which people often don't enjoy. But people do often find that when they lie down in bed, that's when they start cough, 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 for the same reason, is that those secretions are moving to an area where it's stimulating the cough. We still often do recommend modified postural drainage positions, so still doing breathing exercises in side lying with the right angle of prone or supine, but not so much head down tilting. And then there are some other devices which work on the principle of positive expiratory pressure. So this is the little device that the chap was using on TV last night, if anyone saw him. And this is called PEP. And what PEP does is you're breathing out with a prolonged expiration against some resistance. And the idea is that when you're breathing out against resistance, you're actually causing some back pressure in the airways, you're splinting the airways. So again, you're using that collateral ventilation to get air in behind the secretions and help to move them to an area where they can be coughed up. So with the PEP device, they're not actually that cheap, and they're again a one-use wonder. And you do need to put a manometer on them, which is a little pressure gauge, to get the right pressures for people when you start using it and training them. So what has been used in kiddies, which is a little bit cheaper, is what's called bubble PEP, and that's literally blowing bubbles into a milk bottle of water, and it's actually been found to be really effective, and it is used on some adult wards as well now. So with the PEP, usually people are instructed to do 6 to 10 breaths, have a little rest, 6 to 10 breaths, have a little rest, and by that time they'll probably be coughing up the secretions. It is actually quite hard work. If you've ever tried to do it, you'll find it's really exhausting. It's a good device for particularly young people who need a gadget to help them be more engaged with doing their exercises. If you say to someone, go and lie down on your bed and do breathing exercises, well, you might fall asleep or you'll get bored, and the compliance is often not so good. Whereas if you have a little toy, then it can just help to make those exercises that little bit more interesting. After PEP, they developed oscillating PEP. The first one was the flutter. Didn't have a very good picture, but the flutter's like a little pipe, and sits within that pipe is a little steel ball. And it's the same concept as you're breathing out against a little bit of resistance, so it's that long, slow expiration. But the little ball, steel ball that sits within the pipe or within the device has a fluttering effect, which causes oscillations within your airways. It's a really unusual feeling. And what that does is those oscillations in your airways have a shearing effect and help to loosen the secretions, to mobilise them again so that they can be coughed and expectorated. The flutter has been around for a long time. The difficulty with the flutter is you need to sit at a table with your arms resting, and you tilt the angle of the flutter to get a different level of resistance, which is not very scientific and really hard to reproduce that same angle. So then the a cappella was created, and the a cappella is position independent, so you can lie down and do the a cappella, or you can sit up, and you can change the resistance on the device. So the green one is the a cappella. So it creates vibrations within your airways, very low frequency vibrations. They say between 0 and 30 hertz, but actually it's more in about the 8 to 12 range. And again, like the PEP, you sit down and do a series of breathing exercises for 15 minutes, ideally twice a day, to help mobilize those secretions. So I guess my take-home message is just to make you aware that there are options around to help people who have difficulty clearing their secretions. There is no one best fit. At the end of the day, the active cycle of breathing technique is very effective, but what works best is finding a technique that somebody will do and will stick with as part of their regime. And usually that means a little bit of variety, mixing it up with different devices at different times. Yep.
So I was going to finish off the session before afternoon tea, which you all deserve. It's been a pretty hard day and we've been really pushing it out there, haven't we? So I'm going to go through this pretty quickly, but it's really just to make some of the points that I made earlier on in the day. But, you know, we've talked about asthma in general. What about the severe asthmatics? And they make up, you know, if you use a definition of severe asthma, about 20% of the total asthma population have what are described as severe asthma. And probably half of those are severe because of non-adherence. We've talked about that. Or they're on suboptimal treatment. And the reason for concentrating on this is not only to try and help the poor people who suffer from severe asthma, but because they actually represent 4 times the economic burden of the rest of the asthma population. So this is just some reflective information. I'm sure if you go to your own local hospital or extract it yourself, you'll find something similar. But these are adult patients in the year after discharge from Middlemore Hospital. 86% of them had actually required another course of oral steroids, and almost 60% had 2 lots of oral steroids. They were mainly picking up their short-acting beta-agonists, but for some reason a few of them weren't. And only 18% had picked up 7 or more inhaled steroids, which means that it's only about 18 or 20% that are actually fully compliant with their inhaled steroids. So for the majority of people who are being discharged from hospital, it ain't that they've got severe asthma, it's that they're impoverished, they've got fragmented care, and they don't need to see me. They really need to have a system of care around them. And so what I've got some funding for is I'm going to start using the smart inhaler device. It's the Wi-Fi based inhaler. So we'll work with them with an app. We're working with Vodafone on that. And we'll keep in touch with them and be able to evaluate their compliance. And more importantly, when they start banging away on their Ventolin, we'll pick that up and intervene and see whether we can help them out. But when I actually start talking to these patients, the last one I saw was a 22-year-old mother of 2, and she's a solo parent, and she said the kids come first. You know, she'd only picked up 2 inhalers in the previous year. And when I said, well, what do you do when you do go and pick it up? Why don't you go and see the GP? She said, well, I went and saw the GP, and it costs $15 for me to go, but if I just pick up a prescription, I only have to pay $5. So I said, well, so at least you get 3. She said, no, he only prescribes 1 inhaler. So she goes and picks up the prescription for $5, goes along, gets a dispense for another $5, and the poor thing has only picked up 2 inhalers in the last year. So her problem is more to do, she was sensible enough, she's putting her kids first, you know. She wasn't watching the airline ad, which is put your oxygen mask on first and then look after your children. She does what most mothers do, is to look after their kids first and worry about herself second. So it ain't me that's going to help her, but I think we've got to put a system of care to better help her, and it ain't going to be from all the things I've told you about. It's a more pragmatic response required. So I'm working with Nexus 6 and Vodafone to try and achieve that. This is the Nexus 6 smart inhaler device. It clicks on the end of the inhaler here, and it sends off a signal. You can get them clicked on not only immediate dose inhalers, but on the turbohaler as well. Basically, there's models for each inhaler that we've got. You can have a reminder beeper on it, and it's got a rechargeable battery. It's got basically it's a Bluetooth communication through the smartphone. Vodafone are going to donate some smartphones. They're also going to donate some 1G SIM cards, because nobody uses 1G SIM cards. We only need 1G to upload the information from this, so we can do it quite cheaply, I think, and we'll see what happens. But severe asthma, otherwise uncontrolled asthma, which can result in a risk of severe exacerbations and death and or adverse reactions to medications and or chronic morbidity, which is sort of like a nothing definition, really. I would have thought that in 2010 or beyond, we should say that it's uncontrolled asthma, which despite maximization of inhaled medication directed by biomarkers, is still poorly controlled and leads to blah, 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 blah. But it's not. It's a fairly bland sort of definition. So what I did was to go back into our asthma clinic and just sort of see what proportion of people who are attending our asthma clinic over a 2-year period actually had severe asthma. And so these people had to have poor symptom control. We took that from the clinic letter. Greater than or equal to 2 courses of oral prednisone in the last 12 months. These are World Health Organization definitions. Any hospitalization for asthma and persistent airflow limitation, which was FEV1 over FVC less than 70%. And they had to, when we looked at adherence, we used this greater than 7 prescriptions of inhaled steroids in the previous year, which we're lucky we can extract from TestSafe. And the maximum treatment was greater than 1,200 micrograms of BDP equivalent. So it's more than 800 micrograms of fluticasone or more than 1,200 micrograms of beclomethasone or of Pulmicort. And the need for a second controller, such as a LABA or Spiriva or a leukotriene or equivalent. And what we found was that of the 480 patients we reviewed, 305 actually had poorly controlled asthma. And of those, 47%, only 47 only were on maximum treatment and who were fully adherent and weren't, of those only 34 actually fitted the formal definition of treatment-resistant asthma. There were 13 who would have, but the reason that they didn't was that they were still smoking and they had important comorbidities such as heart failure that were interfering with an ability to manage their asthma. So they're called difficult to treat rather than treatment resistant. But look at the number here who were undertreated. 13 of these, even if they're fully treated, would have been difficult to treat because they were smokers. A lot of people with comorbidities. Non-adherence, again, came up as a really big factor. 135, almost 60% of patients were maximally controlled because of poor adherence. And as somebody else has mentioned already, that's not unique. If you look at any study on asthma clinic patients worldwide, about 50% of patients are poorly adherent with medication. So adherence is a big factor. So here's the overall, 82% of patients were suboptimally controlled. And what contributed to their poor control? Well, actually, poor symptoms came out as one of the least frequently observed definitions. But one reason for that is that that was extracted from the hospital record. If we had systematically used the asthma control test, we probably would have found that about 55% of patients had suboptimal control of symptoms. Frequent exacerbations, about half. And interestingly, airways obstruction in about a half, and the frequent exacerbations about 23%. So what about these treatment-resistant asthma? It's quite important to look at this group because if you can't control them with available medicines, then you can start looking at alternative approaches. But if you come back to the biomarker argument, 50% of them, despite maximal doses of inhaled steroids, still had inadequate control of eosinophils within their airway. And about 28% of them probably had neutrophils in their airway. So they're not going to get any better from maximizing their inhaled steroid. This group probably needs antibiotics. And it applied whether they had poor symptom control, whether they had airways obstruction, whether they were the exacerbations requiring admission or the prednisone ones. About half of them had persisting eosinophilic inflammation. And if you look at the undertreated group, it's the same sort of thing. About half of them, maybe slightly less in fact, had undertreated eosinophilic inflammation. And yet these people were only on Seretide 125, 25 or Symbicort 206 twice daily. So I admonished my colleagues and said, you've got to do better than that, and they've been doing better since we evaluated the study. But again, about 20% of people in that group that who has probably had neutrophilic inflammation. So what do we do with these patients? Well, they're basically, once they get up to this treatment-resistant group, this is the group up here, and so you should be considering amilimumab. That's an anti-IgE antibody, and it's funded by PHARMAC. So why weren't my clinicians maximizing treatment? Well, there is a study that was published by Richard Beasley and Sean Holt in the British Medical Journal saying you actually get the maximum benefit from fluticasone on 500 micrograms a day. So these guys were all on 500 micrograms a day, so they might have thought, well, what's the point? We've already maximized it. And the point I'd be making is that if they've got eosinophils there, they haven't maximized their inhaled steroid dose, and they should be considering giving more. There could be a concern about the systemic side effects of inhaled steroids, as I mentioned before. There's a high percentage of people who had COPD, and maybe they were concerned about Sami Souza's paper that I mentioned to you previously, that if you elevate the inhaled steroid dose, you might increase their risk of infection. Poor adherence, I pointed out. And the other thing is that if you're using fixed combination treatment, you actually lose your ability to adjust your medications. And here's an example of a colleague of mine. After I gave the talk, she saw the patient. Here he is with a serum eosinophil level 0.6 elevated. He's on serotype, and he's got FEV1, which is 70% of predicted, and he's symptomatic. So she actually gave him a very elevated dose of flixitide, kept him on the serotype, and then saw him 3 or 4 months later. His eosinophil levels came down to the high normal range, probably still not adequately controlled, but a lot better. His FEV1 went up to 2.1, and then she didn't see him again until I saw him after a life-threatening attack at the hospital. I said, what happened? Did you get a viral illness and you suddenly decompensated? He said, no. He said, I haven't been feeling well for a number of months. I said, why? He said, well, the pharmacist and my GP both told me to stop taking the flixitide because it's already in the serotype. And so I stopped taking it, and phew, this is what happened. So this sort of creates confusion. A lot of people think, oh, well, you're getting it in here, so why add an extra? That makes the point that, I know there's some pharmacists here, I'm not trying to make a point there, but we should be working as a team and in a community and saying, this is what we're trying to achieve, and make sure that the pharmacists are aware if we're going to add in monotherapy in addition with a combination therapy, everybody is aware of what it is you're trying to achieve. They were trying to achieve better control of the inflammation. She lost it, and that made him vulnerable to a super-rapid attack of asthma.
That's the general thing when you're prescribing, say, 2 different doses of our beta blocker. Yeah. You've got to put in the instructions in addition to such and such. Yeah. Because it's easy to say, just repeat one of them. And I've seen that quite a few times. But, yes. I mean, really, that's what, the instructions, it's easy to click one, repeat one and not the other. So you need a kind of a signpost there to remind you.
I agree. I think it's a limitation of having combination therapy is that really what you're trying to do. I mean, all the Symbicort smart Haler studies showed that you could elevate it. If you actually look at the Symbicort papers, all the patients who were recruited into those studies were on 800 to 1200 micrograms of BDP equivalent, the Pulmonary equivalent, if you like, a day, and they were submaximally controlled. Okay, at the time of entry into the study. They were then randomized to taking 2 puffs of the Symbicort twice daily, which they were already on, which wasn't controlling them, or to use it on a PRM basis. Now, if you look at the study intervention group who used it on an as-required basis, they ended up taking more because they weren't controlled. So they ended up taking a dosage of inhaled steroid which was higher than the control group, and they did better because they got more inhaled steroid. And that's why the smart Haler intervention worked. But if you try and do it on their behalf, which is what this clinician was doing, it can confuse everybody else that's involved in their care, thinking, what are they doing? It's already got it in here, and therefore lose sight of what the goal you're trying to achieve. One of the thoughts, I mean, what I personally do, I actually was talking to Robin Taylor, who's a noted pulmonary physician from New Zealand, who's done some really good work in in asthma. He's gone back to Scotland, but I was just talking to him the other day about QVAR. I said, what do you do? And he said, well, if I don't get optimal control here, I add in QVAR into this, and that's what I must say I've been doing for about 10 years. And QVAR actually is very useful in this context. And it stops the confusion about adding in the inhaled steroid. There was a poster about 3 years ago, the American Thoracic Society, a respiratory physician had used QVAR in addition to serotype. He found that 65% of the patients actually achieved good control with the addition of QVAR to the serotype in just this situation. I think we were basically, what do you do then if you're confronted with severe asthma with eosinophilic bronchitis? Well, not relevant much to you guys because you're in primary care going to refer them on to us, so I'm not going to spend too much time on this other than to say that around the corner we're going to have biologics available. The one that's available now is a monoclonal antibody against IgE, which does reduce exacerbations, but it's very expensive. And so we do need to ensure that we're targeting it in the right patients. But what do we do with people who've got non-eosinophilic bronchitis, i.e. neutrophilic? I'll talk to you more about this later, but macrolides are obviously an important part. These patients are also more likely to be derived from people who are overweight. And 60% of our patients who are in the severe category had in that treatment-resistant category, had a BMI of more than 40. And so the biggest problem, I think, for them was weight, and we need to get them to lose weight because that'll have the biggest impact on their asthma control. I won't just. So I just presented the Thoracic Society of Australia and New Zealand. There's a Australasian database that we're developing, but I think that, in terms of accessing the biologics, New Zealanders, wherever they are, need to put patients on the severe asthma database. And from there, in New Zealand, we need to ensure that we've got the right criteria for accessing the more expensive biologics. And we also need to audit how we get on with them and how the patients respond to those treatments rather than to use them as individuals. I think we need to, it's a responsibility we have as a community to evaluate how patients get on. And the only way we're going to do that is to look at it systematically.